Hello, Nurse Linda here. And again, this is just geared towards fertility medications and medications in general, that kind of thing. But you are, like I said, you're welcome to ask any questions at all about fertility medications. We'll go over, like I said, you guys submitted a lot of questions. So we're going to be able to hit on probably most everything that you guys brought up. All right, we are growing in leaps and bounds here. So like I say, if you guys want to submit any further questions to me, you're welcome to. All right, so let's go ahead and we'll get started. And one of the very first questions that came up is for gals who are on medications, and they're looking, to when they should progress to going and seeing a fertility specialist. How do you know when it's the right time to go to an infertility specialist? I was on Femara previously. Well, generally, docs, and this could be OBGYNs, it could be you're already at a fertility specialist, they will generally do maybe 3 to 4 cycles of fertility medications before they get to the point of saying, well, this is a fail. It's easy to prescribe oral medications. Most of the time, they're prescribing oral medications and sending you home and doing your LH kits as usual and seeing if it worked, kind of thing. So it isn't a lot for most docs to do. That's why they freely do it, maybe more often than they should. But after about 3 or 4 cycles of some oral medication like Clomid or like Femara, generally the docs will say, well, this is not working. We need to progress to the next thing, which is generally going to be injectable medications if oral medications don't work. That's pretty much how it works in the way of progression. Somebody asked about the pros and cons of Clomid for ovulation. So the big pro with Clomid or Femara, they're both oral medications you take. Both of these are given and prescribed, and they're basically to assist in ovulation. Now, there are plenty of folks out there who, like me, don't ovulate, have PCOS. I'm going to need a little help. It's not going to happen on my own. So that's what the medications truly are made for, to make, or at least attempt to make ovulation occur. So that's why. Now, why then are lots of women who are already ovulatory women, why are they prescribed this? Remember what I said a minute ago? It's really easy to do. That's why. Now, let's take a gal who ovulates regularly, every month she's ovulating, charts look beautiful. Will Clomid or Femara help her? Maybe a little bit, because it can cause you to what's called super ovulate. So instead of ovulating the 1 egg, you usually ovulate each month. You may ovulate 2 or 3. Of course, you appreciate that means you're at risk now for multiples. And of course, because you're just having intercourse at home type of thing, or even for women who are having inseminations, we can't control how pregnant you get. So that, of course, is one of the big cons of taking these super ovulatory drugs. Now, Clomid especially is known to not necessarily work for PCOS women. I did, 4 attempts of Clomid, increasing the dose every time, and I never ovulated on it. So it is difficult to sometimes get PCO women to ovulate while they're on Clomid. Femara has a little bit more success. So oftentimes Femara, or Letrozole is the generic term for it, that is used probably a little bit more often. Clomid also has a side effect after about 6 months of consecutive usage of actually being more like a birth control. It actually decreases your chance of getting pregnant, because part of what Clomid does is reduces your estrogen, and over time, that's not going to be a good thing, because we need estrogen to grow a nice lining to implant a baby. So again, long-term use, your doc should not have you on these medications longer than 6 months, but especially not Clomid longer than 6 months. Okay, next question was Letrozole versus Clomid. Well, like I said, Letrozole is the newer drug. Letrozole has a little bit fewer side effects, and and it is used more often in PCOS patients because Clomid doesn't necessarily work as well, at least. Okay, I'm just like answering all my own questions as I move forward here. Why is Letrozole prescribed to women with PCOS rather than Clomid? Because now, again, even though Letrozole and Clomid basically are doing the same thing, they're assisting in ovulation, they do it with completely different mechanisms, hence why Letrozole can work in PCOS versus Clomid. So Letrozole is definitely used more often with PCOS. Next question. What is the success rate of using Clomid to conceive? Well, for one, I can't give any one person a success rate because, of course, it depends. What is your personal success rate as it is? So if you're, 32, you may have a chance of, every month of, 7 to 10% of getting pregnant. Maybe when you take Clomid, that's increased to 12%. So like I said, for women especially who ovulate already on their own, it may increase your chances a little bit over whatever they naturally are not on the Clomid. Because again, it could cause you to super ovulate. And of course, the more eggs you put out there for those sperm, the more likely we are to get pregnant. Okay. I am on cycle 3 of trying to conceive and haven't had a peak high at all. What does that mean? Now, of course, this is geared a little bit more towards ovulation. And again, it's hard to say. Basically, what she's saying is my LH sticks aren't showing that I'm ovulating. So it's showing you're not having an LH surge. So specifically, you're not ovulating if you're not getting an LH surge generally. Again, it could be your PCOS. And again, if Lord knows if back in my young days, if I were to do the P sticks, trying to figure out when I ovulated, I would need to take stock in Premom because I would have needed that many boxes to try to catch an ovulation. So again, PCOS, it's difficult to catch ovulation on. Can Metformin help with ovulation? Short answer is it could, because of course Metformin is a medication that is taken to help with mostly the metabolic side effects of PCOS. But Metformin, though it does have some oftentimes unpleasant GI or tummy side effects, again, it can, on many PCOS women, bring them to some kind of normalcy where, again, they're going to ovulate and have any kind of regular cycles at all. So again, Metformin can help with that, and oftentimes PCOS women are prescribed Metformin. What are the advantages of inositol, and can it be taken with Letrozole? So inositol is a supplement. It's a supplement, and much like Metformin, it is a supplement that is often recommended. You just buy it over the counter. Is recommended to women who have PCOS. Because, again, it's more about the metabolism of it that it assists with. So certainly you can take inositol. I take inositol, not because I need to ovulate, but because I just want to make sure I keep all of this PCOS metabolic issues in check as well. But it's perfectly safe to take with Letrozole, too. Some more questions. Letrozole, how many cycles until it's considered a fail? And we talked about that a minute ago. So usually your doc will go about 3 to 4 cycles. Again, some docs will go up to 6, but you don't necessarily want to be taking these medications for longer than 6 months. And again, they're not working, so we need to move on to something else if that's the case. There's a question there about spotting and Letrozole. And spotting can happen. Spotting is not is not anything to worry about. Spotting happens when there's changes in our hormones, fluctuations in our hormones. It's kind of like, if you will, a sneeze from your uterus. It's not a period. It's not a blood flow. It doesn't mean something has failed. It's just that. It's just spotting. So yes, you can get, especially around the time of ovulation, in that you can get spotting while you're on Letrozole, and it isn't anything to worry about. How do you know when you need infertility care and meds like Femara or Clomid? Well, the general formula is, if you are under 35, try, use a Premom app, use LH kits to help you, and, give yourself about a year. of really good trying if you're under 35. And if you're over 35, because time is not as much your friend, they're going to say something like, give it a try for 6 months. Of course, when I do consults, I always encourage patients to get an HSG, hysterosalpingogram, done. Let's make sure those tubes are open. I always encourage to do some kind of male testing, like the kind of things you can buy off of, Amazon. And these are just sperm tests that you can do at home just to make sure there's no big problems there and we don't waste any precious time. Let's see, next question. If you are breastfeeding, is Clomid less effective? Well, Clomid is not less effective because you're breastfeeding. It's usually more like breastfeeding is not as effective if you're on Clomid. Clomid can affect your milk supply and that type of thing because, again, Clomid can be a anti-estrogenic drug. And so those are hormones you need to be able to breastfeed, etc. So, yeah, you can take Clomid. They say it doesn't cross over to the baby through your milk. But it can, because, again, remember, we're playing with hormones here, and your hormones are dictating your milk supply. Somebody asked if they can take too much progesterone. Well, you don't want to take more of anything that you need, right? And generally any kind of progesterone supplementation works because you're taking it and now you have it in your bloodstream. But keep in mind when we say too much, when you're, once you ovulate and your progesterone is up in the double digits or teens or what have you, otherwise it's very low. When you get pregnant, it's going to increase potentially even further. It could get up to 50 or 100 even while you're pregnant. So again, our progesterone levels can be very high. When we're pregnant, our body's fine with high levels of progesterone. But again, your doctor will prescribe for you the amount. It's not anything to worry about like, oh, shoot, my progesterone level's too high, so I can't get pregnant. It's just that you might be taking unnecessary extra hormone that we just don't need to. Are there any other medications that women talk about a lot, in my experience? Certainly right now we've been talking about oral medications, right? Again, the two biggies are Clomid, which is generically, it's called clomiphene citrate or Serafine. Clomid is the brand name. And Femara is the brand name for Letrozole. So these are two medications that pretty much act the same, meaning they do the same thing. They are given to assist in ovulation, which again, these drugs are very important for women who don't ovulate, like myself. These drugs are important. Unfortunately, they did not work for me, but that's why they're taken. Now, what if they don't work? So, again, my experience, what happens if you're, for whatever reason, but you take these oral medications and nothing happens? Crickets, nothing. Well, the doctor increases the dose and you try again next month. Crickets, nothing. Radio silent. And that's what happened with me. So you have no choice but to move on to stronger medications, which will be your injectable fertility drugs. So injectable fertility drugs, which are generally, they're little, with little tiny needles. They're subcutaneous injections, generally done, pinch up a little bit of fat on the tummy type of thing. And these medications are given. And again, remember the oral medications I mentioned will cause, or generally will cause like a super ovulation so that we're not ovulating one egg, but maybe we're ovulating 2 or 3 or what have you. Injectable medications will generally bring on even more eggs. Again, as I always share my story as well. Oh yeah, that happened. Oh sure. You will respond, assuming your ovaries are respondable. You will respond to the injectable fertility drugs because injectable fertility drugs go straight to the ovaries. Whereas the oral medication deals with more of our pituitary and our brain, and they try to cause us to naturally ovulate through our own hormones. Fertility drugs are the straight hormones that you just get them. So again, you do respond if you've got ovaries that will respond. Of course, and my problem was, as many PCOS women, we have tons and tons of tiny little baby follicles that just sit on our ovaries doing nothing. Of course, follicles hold our eggs. So in other words, somewhere in our haphazard way of trying to ovulate each month but failing. We grow a follicle to a certain point and then it stops, and then maybe next month I do it again and it stops. So when I take these fertility injections, everything springs at once. And that's exactly what happened to me. And those cycles got canceled because, of course, no doctor wants to risk you either having intercourse with 20 follicles growing or doing an insemination, because the risk of high order multiples is extremely high, and nobody wants to take that risk and have another octomom on their hands. So in injectable infertility drugs are the next step. And of course, theoretically, the next step after that would be the very same infertility drugs, generally given at higher doses, because now you're stepping into the arena of doing IVF or in vitro fertilization, where we are fine with lots of eggs because we're going to take them out of your body, make embryos in the laboratory, and most likely only transfer one embryo back, so we'll always just get a singleton. So that's kind of the progression, if you will, of medications in this infertility journey. If you guys have any questions or anything more specific I can answer for you, please feel free to shoot them to me here and we'll answer them. Or honestly, I love to talk, so any questions at all? If you guys have something that's on your mind. I'm looking to see if I can see any more questions that come up. All right, let's see. We've got another question. Other advice of what to consider when it comes to deciding to start medications. Well, again, generally, if you're a gal who's using Premom and you're ovulating regularly, you're getting your peak, you're getting your ovulate, your BBTs going up the whole 9 yards, and you're functioning, and you've been doing this for whatever it might be, 6 months or a year, and we're not getting pregnant. Well, first, again, before we get involved with medications, we need to really start considering some testing. Again, I always shoot for the two most obvious, which are the HSG test, the dye test, where dye is injected through the cervix with a little cannula, and that dye is watched with an X-ray so we can see if the dye goes out the tubes, so I can see if your tubes are open. Very important. And getting the men tested. There is no way to test a woman's egg quality, meaning I can do laboratory work, blood work on a woman, FSH, AMH, anti-Müllerian hormone. These are blood tests that point more towards an egg supply, per se, right? So those, but like I said, those don't stop us from getting pregnant. Those answer questions maybe about how long we've got to work on getting pregnant. But that dye test and some kind of a sperm test, I always recommend those before we move on to anything else after our 6 months or a year has passed. Otherwise, again, I'm not one who's big for advising medications if you don't need them. And I always question, if I've got a gal and she's ovulating normally every month and it hasn't happened yet, again, putting her on Clomid or Letrozole may make her ovulate another egg or so, maybe. But it doesn't necessarily make any large difference. At that point, again, in that 6 month, if you're over 35, 1 year, if you're under 35, it is time to either seek out our OBGYN's help or a reproductive endocrinologist at which they specialize in treating women with infertility. So that's, generally the route that I go when I'm making recommendations to folks. Any other questions? Give it a little time. What else can we talk about? Well, I do consults all the time, on the Premom app, or even on your phone, you can click on other and you can see there's just a whole gallery of us providers. Find a provider that you like. Find a provider that you feel like you have a good vibe with. We're all extremely knowledgeable. We all pretty much can help you and answer questions and do all that. It's a good group of people. And you're always welcome to schedule consults. I had a consult I do repeat consults because folks, we come back, it's chatting. It's even sometimes like therapy. And I love doing that, and I'm happy to do that. And I had a little gal just book a second consult with me, and I figured we were just gonna, she's getting smarter and we're talking about more complicated things, etc. And she actually scheduled a second consult with me just simply to tell me she did what I recommended she did, and she found out she's pregnant a week ago. And so we're very excited about that. I always tell everybody, put a little pillow under your bottom when you're trying to get pregnant, and she did that, and she swears the pillow made it happen for herself. So I love that. So you're always welcome to reach out to me in that regard. Let's see. We've got a couple questions here. We'll see. Okay, somebody's asking a question about endometriosis. How long after a laparoscopy will endometriosis start growing back? I feel like it's affecting my fertility again. Yeah, endometriosis is a real B word. Yeah, it is. It's like PCOS. It's difficult, mostly because it's so darn painful. So you can have laparoscopy to laser off those endometrial growths that happen. And of course, all that is just part of your lining escapes out through the tubes and lands wherever the heck it wants, on the outside of the uterus, on the outside of intestines, anywhere on the inside of our abdominal wall, on the outside of ovaries, wherever it feels like it. And just like our lining in the uterus grows every month and then we shed it, and it grows every month, all these little endometrial deposits that are in places they're not supposed to be will do the same. That's why laparoscopy will never get rid of endometriosis, because it will keep coming back. So you're absolutely right. How long does it start? Well, it starts growing back as soon as you start growing a lining, but it doesn't start to generally impact you till it's gotten to a certain point. That's why women will go in and they'll have laparoscopy to get rid of their endometriosis, but they know darn well they're probably going to have another one in 6 months to a year because it's going to grow back as well. And does it impact your fertility? Well, some doctors, and certainly the doctor I worked for, was a big believer in there are immunological reasons that endometriosis can impact infertility. That's a very complicated place to go to, though. Somebody is asking about they're taking Premom while they're taking Clomid. Remember I mentioned a minute ago, one of the downsides with Clomid is it's an anti-estrogenic drug. That's what it does. It lowers your estrogen, which isn't always a good thing. So guess what Premom is? Estrogen. So that's why your doctor's prescribing Premom. So I think that's about it for now. I don't see any more questions, and I don't want to hold you guys up. Like I said, you can find myself and any of the other lovely providers on the Premom app, and you're always welcome to reach out. I'm always available. You guys have a great night, and I look forward to talking to y'all soon. Bye-bye.